Thank y'all for coming to the GASPN meeting. My name is Adina Hirsch. I'm the former past president of GASPN, and I'm now on the GASPN board, and I'm a co-editor of our bi-yearly newsletter. So it is my pleasure to introduce our last speaker, Dr. Dante Ye, who is an acute care surgeon at Ryder Trauma Center in Miami, Florida. He completed his general surgery residency training at Jackson Memorial Hospital and fellowship in trauma surgery at the University of California at San Francisco. He serves as Associate Program Director of General Surgery Residency in Jackson Memorial Hospital since 2017. He is a clinical expert in advanced nutrition support and is a fellow of Aspen since 2020, intestinal rehab and complex abdominal reconstruction. He has authored nearly 150 peer-reviewed publications and nearly 20 textbook chapters and review articles. He is an active member of Aspen, serving on several Aspen committees over the years. And as we stated, he's both a fellow of Aspen and a fellow of SCCM. We look forward to benefiting from his expertise as he discusses the 21st century management of enterocutaneous fistulas. Dr. Ye?
Hi, thank you, Adina. Can you signal to me that you can hear me okay?
Oops. I can hear you and I can see your slides.
Okay, great. I just have to figure out how to get rid of this control panel. Let me just push this button here. Okay, all right, that worked. Okay, great. Well, thank you very much. I'm honored to be here, and I gladly accepted the invitation to talk about one of my favorite topics, enterocutaneous fistulas, which makes some people question my mental health. But there's a lot of interesting stuff going on, so I'm happy to share with you our experience. Let me see here. Okay, so I do have the following disclosures. Though I did add one since I submitted my slides, which is that I participated in a virtual advisory board for Baxter. Everything that I'm going to be talking about in this lecture is evidence-based to the best of my ability, and I will try not to make any off-label recommendations. So at the end of this 1 hour, the learner should be able to understand and apply the three-phase approach to the treatment of fistulas, describe the step-up approach for treating, for treating nutraceuticals, and then also discuss the appropriate steps for initiating fistulolysis and reinfusion of succus entericus. So before I begin, I'd like to just highlight the team that I work with. It is a multidisciplinary team led by two surgeons, Dr. Patricia Byers, my mentor and partner, and myself. But we couldn't do nearly anything close to what we are able to accomplish without the help of our other team members, including our pharmacist, Carly Duncan, our dietitian, Lindsay Gass, and our nurse practitioner, Patricia Machado. So this is the core of our team. We also have rotating residents and a fellow. This is sort of what we do. We do intestinal rehab. We do all sorts of advanced nutritional therapy. We do surgeries, of course, for the enteral access and also to rearrange anatomy. But I think the most important service that we provide is that we provide a medical home for these fistula patients, and that can be so important because oftentimes they get lost in the cracks and they get fragmented care. So we kind of consider ourselves a surgical rescue service because most of our patients actually have suffered complications at the hands of others, and they don't really know who to turn to. So we've sort of collected all of these and developed a lot of institutional experience and knowledge in treating these complications. I did want to share with you some data from our own team. This was presented 2 years ago at Clinical Nutrition Week, and the manuscript has been submitted. But just to give you a sense of what we do and what our outcomes are. So my mentor, Dr. Byers, has been leading this team for over 25 years, and so we basically reviewed her outcomes over the years, and we tried to get an understanding of what the outcomes were at the last visit, at our last encounter, and we defined intestinal failure as requiring any sort of parenteral nutrition or IV fluid requirements, and then we used the term nutritional independence to mean that the patient was eating oral diet and completely liberated from parenteral and enteral nutrition. And so over the course from 1989 to 2016, our team had treated a total of 89 patients, a lot of whom had very short segments of bowel. As you can see, the average age was about 56 years, slight predominance in females, and the median length was 80 centimeters. All right, what that means is that half of the patients had even less than 80 centimeters, right, if that's the median, and most of them, just over 50%, had enterocutaneous fistulas. Now, the majority of them ended up going to surgery, and the majority of those operations were successful with a success rate of 75%. And what I wanted to highlight is that at the end of our treatment, at the last encounter with the patient, nearly 3/4 were off of TPN, and about half of these patients were nutritionally independent, meaning that they required no sort of IV fluids, parenteral or enteral nutritions, with half of them having intestinal lengths less than 100 centimeters. And here you can see the progressions from when we first met them. The majority of them had intestinal failure to the last encounter. And I do want to highlight that due to perseverance and a stubbornness to accept dogma and say, oh, that can't be done, we've been able to achieve nutritional independence for patients who you would never imagine in your wildest dreams would be able to eat normally. For example, somebody with a 15 centimeters of small bowel. And so in the interest of time, I'm going to just jump ahead to the conclusion, which is that with our surgical service, we can rearrange anatomy, right? We can take somebody with an endostomy and connect them back to their colon. We can do intestinal lengthening procedures if we need to. And then with this medical home concept, with this dedicated multidisciplinary team, we can achieve fairly optimistic parental nutrition liberation and nutritional independence rates, which are much higher than what we've encountered in the published literature for this patient population. And so I want to encourage everybody, who's here, no matter how short the bowel is, if you have a compliant and motivated patient and a very dedicated team, just about anything is possible. It's really impressive, the ability of the human body to adapt. So again, this is the environment from which I'm coming from and what I'm practicing within. And so I'm going to go ahead and start by sort of giving a brief historical perspective of fistulas. Some of the earlier reports are from about 40 years ago, from the Annals of Surgery, looking at this series of 400 patients. And historically, the diagnosis carried a pretty severe prognosis, pretty grim, 44% mortality, which improved given the improvements in anesthesia and peri-operative antisepsis and all that. And then we have a big milestone in the 1970s with the introduction of hyperalimentation, which at the time was felt was a gift because they were able to nourish patients, but I think at the time they were a little bit misguided in applying the, if some is good, then more must be better, and a lot must be really good. So I think that the era of hyperalimentation as we know it has come to a close, although you'll still hear some older physicians refer to TPN in general as hyperalimentation. Again, here's another historical paper describing about a 70% success rate and a mortality rate of about 21%. When I was in Boston, I worked at MGH for a few years, and we decided to do a retrospective and look at our current practice of fistulas and what we were actually. There were two prior publications in the literature from the same hospital, from Mass General Hospital. So we compared within the same institution, how did the treatment change from the 1960s to the 1970s to the mid-2010s. And here you can see the progression in improvement of outcomes from 44% to 21% to 3%. You can see how parental nutrition came and then basically went, and such that the minority of patients by 2015 were actually receiving any form of parental nutrition. And you can see that how the operative success rates improved dramatically. I think one of the reasons for success is the recognition that the longer you wait, the better your outcomes will be. And so in our 2015 paper, the median time to repair for a fistula was 12 months. Looking nationally, the burden of fistulas is quite high. The mortality rate is about 10% nationwide, and this complication, I would call it rare. It's about 1% after abdominal operations, but it's not so rare that it's that you won't be seeing it. And I'm sure everyone in the audience can think of immediately a patient right now in their hospital that has this devastating complication. My former colleagues went on to publish, without me, by the way. They published a nationwide review, and this is now what I quote to patients, right? So I personally think that this is the highest level, the best prognosis that I can give to my patients. I say about 50% chance that if I operate on you, you're going to have some sort of complication. Thankfully, most of the time it's infectious and it can be managed without additional surgery. However, you have about a 10% chance of needing to go back to the operating room within 30 days. And again, I quote them a 10% overall mortality rate. This should be compared to overall emergency general surgery, which, I apologize that the font is a little bit small, but you see that the mortality rate is slightly just under 2% and a complication rate of 10%. So within the greater, Venn diagram, within the greater pool of emergency general surgery, enterocutaneous fistulas are really weighted towards this more severe end. So this is a very serious disease, which is far more morbid and lethal than most of the other diseases that I, as a general surgeon, encounter. So the goal of this lecture is, when you, as the clinician, whether you're a dietitian, a pharmacist, a nurse practitioner, a physician, whomever, when you're encountering a patient such as this, I hope that what you take away from this is that you'll have a structured and organized approach to the management of these patients, such that when you see this, you're like, no worries, I got this. All right, so that's the goal. So it's good to sort of just approach it in a very logical way, where there's 3 phases, and we call them 1, 2, and 3: recognition and stabilization, anatomical definition, and then definitive operation. And this is actually this publication was from Bill Schechter. He was a surgeon in San Francisco who I trained under during my fellowship at San Francisco General. So the first phase of recognition and stabilization is really just getting to know the patient, right? We just got a new consult for a fistula a few days ago, and I said, all right, well, it's going to take me about a week to really get to know this patient, right? I need to spend some time to review the anatomy, the operative reports. I need to know, where is this coming from, what's their history, and what is going on here, right? So we have these general classifications, and here's an example. Like, these 3 examples: a 42-year-old well-nourished man, low output, colonic fistula from a benign disease. You're going to approach this patient differently than a 67-year-old woman with a moderate output, spontaneous fistula. She also is malnourished, and she's got uncontrolled Crohn's disease. that you're going to also approach differently than you will a 21-year-old with a high output duodenal enteroatmospheric fistula who just and with an open abdomen, and this is a failed repair of a GSW. So this is where being able to correctly classify and label the fistula is very important. And I see all sorts of misnomers and incorrect classifications. So when I receive a consult from another hospital or another physician, I basically start from square one, and I don't take anything for granted, because this is kind of important nuances that will color your approach to this patient and your understanding. The fluid and electrolyte management is pretty straightforward. I don't think I need to lecture this group about how to do it. But one thing that I do is, no matter how long the patient's had the fistula, no matter who it is that they're referring to me, the first thing I do when I meet a patient with a fistula is I put them strict MPO for the first few days in order to simplify their fluid management for a second, and also to get a good understanding of what is their baseline fistula output with any sort of GI stimulation. All right, I just want to know, is it like minimal? Is it 200 a day, or is it like a liter a day if they're strict NPO? So this gives you a starting point and a point of reference. During this time, you'll be repleting the electrolytes and fluids, treating acute kidney injury, whatever. The most common, that we found anecdotally and that I've read in the literature are sodium, potassium, and magnesium. But again, anything is really possible. There are also some micronutrients, like most commonly zinc, that are oftentimes deficient in these patients. So my rule of thumb is, if they have any evidence of macronutrient deficiency, then I always screen them for micronutrient deficiencies as well. All right, so that's the first part of phase one. The second part of phase two is pretty straightforward. You want to, I always get a CT scan with enteral contrast, and I'm basically looking for anything that could be controlled or treated with a needle and a drain. And nowadays in the 21st century, pretty much just about everything can be managed percutaneously, and should be, so you don't go in there and muck things up and make it worse. So this is another cornerstone of the early phase one management of a fistula patient. Now, nutrition, which is what we're all here for, I would say that it is very unlikely, it's possible, but extremely unlikely that a fistula, especially anything other than a low output fistula, unlikely that it's going to close spontaneously in the first week or two. I do the bowel rest at the beginning when I'm getting to know the patient and just to catch up and stabilize their fluids. But after that, basically I challenge them. I give them food. I give, if they're not able to eat well, we put in a feeding tube, nasoenteric or a percutaneous feeding tube. But we do anything to supplement them so that they're not solely dependent on parenteral nutrition. So in some cases, it's absolutely necessary, so they just don't have the appetite, or it comes right out. If you have a very proximal fistula, it comes out in 15 minutes. Sometimes you have to, but nowadays in the 21st century, we are very aggressive with offering and encouraging oral or enteral intake. Okay, so the next section is more directed to the surgeons, but for those of you who are not surgeons, you can sort of encourage your surgeon. The fistula, if you can actually divert a fistula like you would divert a river, right? You can force it to follow a path of your choosing, and you can make it the care of this patient much easier, and the future operation of the patient much easier. And sometimes you can even change the course of whether or not it'll close or not by forcing it to follow a path of your choosing. So I'm going to give you an example of a young woman that I took care of. She was transferred to me from Jamaica after a car crash, and as you can see, she's got bile coming out of the lower part of her incision. It's being temporarily managed there by a sump drain, a nasal gastric drain. You see that she's got her colostomy up in the upper hand corner, and so this is a disaster. She's got these open wounds, but notice that the wounds are beautifully granulating. It's that beefy red tissue. It's not infected. It looks great. So why would we leave her with this huge wound and have bile just pouring out of the middle of her incision? So what we use is this triple sump drain. This is made by Bard. I believe it's the only company that makes it. It's huge. It's the size of a garden hose. And if we zoom in a little bit on the end, so all the way at the bottom left, you see that there's actually 3 channels. The sump channel on this big disc that you see on the top, that's as similar as an NG tube, the blue sump channel. The central channel is for evacuating the contents. It's the suction channel. And this little channel at the bottom is actually for irrigating. And so what we do is we actually instill fluid into the wound, and that helps loosen it up and thin it out and prevents the channel from clogging. And then the air intake from the sump also helps it from clogging, and then it gets sucked out through the central channel. You see that there's all these perforations at the end of the channel, at the end of the tube, and it's very soft and floppy. It feels like a Penrose drain. So the way that we use this, so as you can see, I tunneled this in from the side, and then I laid it down at the base of the wound, and then I covered I basically went ahead and closed the entire wound. So the fistula contents are coming out of the midline through the fascia, but then they're immediately getting sucked out through this channel and being forced out through the side off of the midline. There's her colostomy right there. So over time, so then we put an incisional vac on this. As you can see, we're irrigating and suctioning, and you can see here on the right panel, you see that it's stained bile, so it's still flowing. But as you can see, the whole rest of the wound has healed up with with a little bit of scarring, but that's okay, and a wound breakdown. But as you can see, it's actually flowing very nicely, and the midline has closed up, and then, while she was in the hospital recovering and getting better, because she was a young 22-year-old healthy patient, even though it was putting out 1.5 liters at the beginning per day, over time with good nutrition and support, the fistula actually spontaneously closed, and we were able to pull out the drain eventually. And then several months later, I went back in. Well, let's say a year later, a year after the original operation, I went back and reversed her colostomy. And so that's the final, and so that was her after everything was all healed up. So, by applying these principles, you're able to take something that seems like a hopeless disaster and actually have a very good outcome. In another example, this was a patient whom I had tried to reverse an ostomy with, and about a 1.5 weeks after surgery, I get a call from his wife, who's very upset that he's got stool coming out of his midline, as you can see, right? So when you see this is not something to freak out about. This is something that we know how to manage. So I took the patient back to the operating room. I could not get into the abdomen because it was completely frozen. As you can see, we have the prior colostomy site, which still had not yet healed up, and the clamp that you see here is basically directed right at the where the fistula is. So I did the same thing. I basically brought in the Bard Abramson drain through the prior ileostomy site, laid the tip right on overlying the fistula, and then closed it back up, as you can see. This is a JP drain that goes deep into it, but as you can see, this is the end of the at the end of that first case. And then what we do is when the fistula output is actually slowed down and decreased, we'll cut the tube and then actually start to slowly back it out, day by day, like 1 centimeter per day. And then as you can see, over time, with good nutrition and support and everything, all the other goodies, we were able to heal this and close it up without leaving him with a big open wound. So here was another success story, and unlike most of the others, this one was actually one of my complications, but thankfully I knew how to treat it. Another cornerstone of the University of Miami method is the Nutraceuticals, which is a mashup of nutritional pharmaceuticals. And I've given this lecture before in an expanded manner at previous Aspen conferences, but this is the summary slide. So this is basically our Fishless starter pack, and the first 3 agents should be very familiar to anybody who treats short bowel, right? So we're going to suppress the secretions of the stomach acid, which, by the way, can secrete between like 500 to 1 liter a day. So we're going to suppress that, and then we're going to slow the GI tract down. We're going to use loperamide and diphenoxylate, which is the trade name Lamotil. And the FDA says, and the package says that 16 milligrams per day is the maximum, but there are plenty of case reports out there, and we have a lot of experience with going way above that. I'm just saying that, you know, I'm not advocating it, but I'm just saying that off-label, that is a potential, but I just have to really, you know, emphasize that it's not, that it's off-label. We also, you know, it's not surprising that a lot of these fistula patients have mood disorders and are depressed. And so we go way back to an old class of medications, the tricyclic antidepressants. So amitriptyline, otherwise known as Elavil, is one of these medications which was no longer favored because of all of the antidepressants, it has a high incidence of anticholinergic side effects, which, you know, are typically slowing down the GI tract. So in this disease, that's actually desirable, right? So you get a 2-for-1, right? You can treat their mood, and you can also slow down their GI tract and decrease their fistula output. So amitriptyline is another workhorse in our armamentarium. Now, occasionally we will use clonidine, but that's not very often because, you know, we don't want to have to worry about the rebound hypertensive effects. But that is also in our toolbox if we need it. And then the supplements that we use to facilitate wound healing there's a proprietary blend of amino acids that includes glutamine, arginine, and HMB. We also supplement oral or enteral glutamine, and then we give a soluble fiber like guar gum, which, you know, will thicken and decrease the watery output. So those are the, you know, this is what we mean when we say, oh, put the patient on the usual fistula nutraceuticals. That's sort of, you know, shorthand for this combination, right? And the overall goal for all of these, you know, treatments is to reduce the volume and increase the thickness, right? You want to make it less easy for it to slip out through that fistula. I'll just mention that our group does not use octreotide. Even I'm aware that the literature out there suggests that it may help, but based on the mechanism of action of vasoconstriction of the mesenteric vessels, we're concerned in our group that it will impede wound healing and adaptation. So at the University of Miami, we do not use routinely octreotide for the treatment of fistulas. One thing that I have also done is I prescribe marshmallows, and this is again something that I found. This is something I found in the colorectal surgery literature. It was a randomized trial which shows that eating marshmallows with each meal can actually decrease the amount of ostomy output, right? So anything that will decrease diarrhea or decrease ostomy output should also theoretically decrease the amount of fistula output, make it thicker, make it more manageable. So for patients who are eating and who don't have an aversion to marshmallows, I prescribe them marshmallows. You got to make sure that you get the collagen-based marshmallows, not the sugar-based ones. That will probably not help. All right. Now, one other thing that we have started doing at the University of Miami is we've started screening all of our patients for relative testosterone deficiencies. And I'm just going to tell you from an anecdotal perspective, I would say that probably more than 75% of the patients that I screen for, that I test the testosterone level, it's either low or low normal. And this can have a lot of implications for their ability to rehabilitate, to regain their functional status, and also to heal. So we used to use exclusively the testosterone patch, the transdermal patch, to treat this, but we have basically experienced a renewed interest in a medication called oxandrolone, which is very old, and it is an FDA approved. As far as I'm aware, it's currently the only FDA approved oral steroid, anabolic steroid, and it's approved to restore body weight after extensive surgery and to offset protein catabolism, which, by the way, is like every one of my patients. And what's nice about oxandrolone compared to testosterone, the reason why we've shifted to using this is because it has tenfold the anabolic activity and only 1/10 the androgenic or virilizing side effects. So it is very safe. You do need to decrease the dose for renal insufficiency, and for elderly, cut it by half. And the most common side effect is a mild subclinical transaminitis. So all of my patients that I prescribe this to, I give them, I do weekly liver function tests. And if you notice it, the AST, ALT will rarely go above a couple hundred. I've never seen it go up to even to 1,000, and it always resolves when you stop the medication. So it's no big deal. All right, so finally, skincare. And again, this is pretty basic stuff. You want to divert the fistula away from the rest of the wound, and I would say that the negative pressure wound therapy, or VAC as we know it, is a game changer. It was revolutionary in the management of fistulas. Now, at the beginning, it can be very frustrating because the wounds will, the dressing, the VAC dressing will often leak, and the nurses will get upset with you, and so we have to be really, really patient and just basically dogged. You have to be persistent like a pit bull. You may need to change it several times a day, but it'll be worth it, because once you get it on the run, it makes it so much easier to manage. So we have two very good enterostomal nurses that I call for every one of my fistula patients. They're like the Fistula Whisperers when it comes to getting the appliances to stick and to capture and control the fistula output. They've taught me so much when it comes to wound care. I'm going to share some of what I've learned from them. And basically every patient is its own little arts and crafts project. So a lot of times, we have this armamentarium, we have this toolbox of all different tips and tricks, and basically every patient is like a trial and error to see which one works for them. So the black sponge was the original VAC sponge. Then they came out with a denser white sponge, which, by the way, can be put directly on top of bowel, and it's safe. And it's less likely to tear apart. We also use a variety of non-adherent wound dressings, such as Xeroform, Adaptic, and Mepitel. I don't have an allegiance to any of these. I just basically use whatever is available to me. But this is good because it doesn't stick to anything. It's non-adherent. And then there's a bunch of little toys that we have. For example, these eakin rings, which it kind of feels like Duoderm. It's these little rings that you can stack up and build a little bunker. They're malleable. You can fold them to whatever shape that you like. And then the stone adhesive paste, I use it like caulk, and I just basically use that to help get a good seal around everything that I'm doing. These wound managers are the next generation. They're basically like ostomy appliances on steroids, and these have also been a huge game changer for managing these large wounds, which otherwise, 10, 15 years ago would not have been able to be managed like this. So I'm going to show another example. This is obviously an enteroatmospheric fistula in a patient with an open abdomen, and unfortunately sprung a leak. As you can see, the forceps are the tip of the forceps are there inside the hole. And so what we did is, you can see in the left panel, I took a Xeroform, cut a hole through it. I put a Mallinckrodt tube through it into the fistula to basically temporarily control it while we're doing the rest of the wound. We put a white sponge directly on top of the bowel, and there you can see in the center is a rolled up black foam sponge. I'll show you in a later slide how we did that. But that's an example of how how you can control that. Now, just a brief aside, the first description of using a VAC to treat a fistula was 20 years ago. It was a case report of a woman who had failed 2 prior attempts at surgery and had a median output fistula for about 6 months. They went ahead and said, well, we have nothing to lose. Now, it was always dogma. When I was in training, it was always basically surgical dogma. You do not put suction on a fistula. That's like you'd be laughed out of the hospital if you did that. But I guess these guys were like, you know what, we really don't have a whole lot else to lose. Why not? Let's try it. So they did it, and lo and behold, they actually were able to heal this fistula within 2 months of treating. So that was the first report. It was a case report. The same group, the same author, followed that up a few years later with a case series of 15, and they reported that they were able to get about 2/3 of these closed, which is great. Now remember, this historically the spontaneous closure rate for fistulas was only about 30%. So this was a huge improvement for being able to treat these patients non-operatively. There followed after that an explosion of case reports and case series of all these people describing, you know, unique ways that they were able to manage this. So I'm just going to give you some examples. As you can see, they're using the zero form and they're able to apply a vac. In this Army publication, they used a baby bottle nipple to actually help isolate the fistula. They cut a hole through the black foam sponge and put this baby nipple through it in order to control the fistula. There's another Mallinckrodt drain in there. Here's one where they actually cover up the sponge with the sticky plastic and then make a series of cross hatches. They'll cut a hole in there and stent it open with these drain tubing. And then use that. So they're placing the suction pad directly over the fistula and forcing the fistula contents to basically come straight up that center channel through those tubing into the vac machine. And they're not setting it at the usual 125 setting that we use. They're using a very low pressure. Okay, and this is basically just to divert the fistula contents straight up into the vac machine. All right, so I can tell you that there, again, like I said, an explosion of literature, and so now in the 21st century, everybody has basically become very comfortable with using VAC, negative pressure wound therapy, to treat an enterocutaneous fistula. This is another patient of mine that I treated in Boston, who unfortunately she was a trauma patient and developed an enterocutaneous fistula, actually enteroatmospheric fistula. You can see again, there's a hole. The wound looks awful. There's old mesh in there that's still infected. And so this is what we did in that earlier case as well. So we wrapped up a black foam sponge with the plastic, and then we anchored it on both sides with the eakin rings to help it sort of keep its shape. We put that directly overlying the fistula, and as you can see, we surrounded it with white foam sponge and the black on top. Covered everything up with the sticky plastic contact sheet, and then got our suction and then cut a hole through that so that the fistula can come out through this little, it's like a little island of fistula in this sea of, you know, black foam sponge for the rest of the wound. And then with that, we were able to throw on our standard colostomy appliance on top of that. We put a drain, it's basically a Foley catheter with side holes cut in it. We put that in the center to help basically suck the fistula output out as soon as it comes out of the fistula, so it doesn't collect and seep underneath and ruin our seal. So, you know, again, this is one of these things where the first couple of days we had to change this often, and it's like a 45-minute ordeal, and it was very frustrating. But with 14 days of tender love and care, you can see that the wound is getting smaller and shallower and cleaner, and on the edges you see that nice beefy granulation tissue. Another almost 3 weeks go by, and now the wound is looking great. So even though you still see some mesh, see that blue line there, that some mesh poking through, the wound is actually beefy red, and it's almost flush with the skin. So it is at this point that we decided to skin graft the patient. So about a week later, we went ahead and applied a mesh skin graft, and then once it healed, we were able to turn a disastrous enteroatmospheric fistula into basically an endostomy, right? And so there she is, fully healed with her skin graft, and then we're able to just manage it like an ostomy. Now during this time, she's eating, she's, you know, doing rehab, she's doing all this great stuff. So we can take a horrible wound like that and turn it into something very manageable. All right, so moving on to phase 2, the anatomical definition and decision. So, you know, we get the CT at the beginning to look for, when I first meet the patient, to look for undrained collections, but I also repeat the CT, you know, months later when I'm preparing for surgery, okay, when we're getting ready and we need our roadmap. So not only do we get the CT, but we also get a small bowel follow through. So we get upper GI fluoro series with small bowel follow through. We also will do a fistulogram, which is either done by me in the operating room or by the interventional radiologist, where we actually cannulate the fistula fistula and inject contrast both proximally and distally. And then finally, we do a contrast enema, usually gastrograph and enema. And the purpose of this is you want to know every single thing you can know about this patient's GI tract from start to finish. How much bowel is proximal? How much is distal? How many do we have? Do we have a distal obstruction? Not only is it good for the surgeon for operative planning, but it also can provide you prognostic information about whether or not you think this will close, and it will also help guide you on, as to whether or not you can do fistulolysis, which we'll talk about later. And then in the final stage, definitive operation, if anything we've learned is you don't want to rush to the stage, because sometimes you won't need to operate at all, right? So there, in the literature, it's a very wide range. It's anywhere between 30 to 70%, and it depends on a lot of factors. But basically, I have seen fistulas, which when I first met them, they were putting out 1.5, 2 liters a day, and I said, all right, well, I'm going to sign you up for your operation a year from now, right? There's no way this thing's closing, right? And then we do all of our ancillary treatments, and we discharge them from the hospital, and then I see them in clinic a month later, and then they get lost to follow-up for like 6 months. I'm like, man, where'd this guy go? And then finally they show up and like, oh yeah, I just was, it just closed on its own. I'm like, holy crap, right? So I have now learned to keep my mouth shut in terms of trying to prognosticate whether or not a fistula will close, because I've been pleasantly surprised and also unpleasantly surprised when I see a low output, benign, non-IBD, and it should close. It's only putting out 5 cc's a day, but 2 years go by and it doesn't close. So I really just stopped trying to predict. But the question is, when should the surgeon operate? And there are various metrics that we use. We generally say, oh, they should be pre-optimized and nutritionally replete, however you interpret that. They should be, free of inflammation. You can generally, measure erythrocyte sed rate, right? The ESR. You can measure CRP. You can look at all these various other measures. I like to tell them that they need to have rehabilitated to the point that they were able to do whatever it was that they were doing immediately before their operation or their their trauma that caused them to get the fistula in the first place. And I also purchased a hand grip strength dynamometer, and I test them when we're in the prehabilitation phase. I say, okay, here's this hand grip strength, let's see. And they squeeze, and I say, look at you. You're only at 40% of what you should be squeezing for your age and your sex. So I'm going to say, I'm going to check you every month, and then when you get to 80% of what you're supposed to be able to squeeze, then we'll talk about surgery. So this gives the patient like a really nice objective measure. It gives them a goal to target, and it's not just some like vague term like, oh, you got to be ready. Like they actually have a goal that they can target. All right, and in terms of time, we have learned that with all the inflammation that comes along with fistulas, it takes a long time for the scarring and the inflammation to subside, and going in too early, you could be carving through concrete, or if you wait a little bit longer, you could be cutting through cobwebs, which is super easy. Okay, so I don't know who to attribute this expression to, but I repeat it like a mantra to my patients. I say, you can never operate too late on a fistula, you can only operate too early. So I say, even if they're doing great, if they're like, nutritionally replete, if all the other criteria have been met, but it's only been like 8 months, I'll say, I'm sorry, if you want the best chance for this to heal up, we'll see you again in 4 months and we'll do your operation then. And I think that's probably contributing to the high success rates of the fistula repair is because of patient selection, or rather forcing the patients to wait until they're more optimized. This is an example of a woman that was actually transferred to me from El Salvador after the surgeons basically gave up. Her original disease was a perforated diverticulitis, but unfortunately, as you can see, she came to me with retention sutures, skin open, and bile just pouring out of the base of her wound, right? She was also obese, as you can see. And so, when faced with this, you can be quite easily overwhelmed and not know what to do. So as you can see, just like the prior example, the the tissue is actually quite good, right? So she's got the beefy red tissue. It's looking like it's healing. So I took her to the operating room. I took out these ugly retention sutures, closed the top of the wound, and then basically applied a wound manager to the base of the wound. Over time, the wounds healed, and the fistula was basically localized to the base of the wound, and as you can see, it's getting shallower. We applied that nice large wound manager device that I showed a picture of earlier, and similarly, we put a sump drain in. This time it's an NG tube to help evacuate that fistula content as soon as it comes out of the fistula. Over time, it became shallower and shallower, and eventually, as you can see, it basically exteriorized itself to look like an ostomy, like a little intestinal nipple there. Also on the base, at the bottom of this right panel, you can see that we've broken apart the eakin rings, and we've used it to sort of help get a seal, because the topography of her abdomen is very challenging with the abdominal folds. So that's one trick that we use in order to maintain the seal. Over time, as you can see, it started to look better and better. And then finally, a year later, I took her to the operating room. I carved in there, fixed it up, and then closed it up. And then I usually leave a G-tube as well, just so that I can trickle 2 feeds and provide a safety net. If they're doing great, this is something that you can easily remove in the office later on. So the final, 10 or 15 minutes or so, we'll be discussing fistula clisis and the reinfusion of succus entericus. And when I describe to my patients and even other medical professionals exactly what that means, this is usually the response that I get. They get this look of disgust, and they're like, "Wait, what? You want to do what?" And I say, "Just bear with me. Hold up." So I think this, when I went back in the literature, I think this is the first description of reinfusing, GI contents back into the body that I could find. And so here we have a patient with a jejunostomy, and we have patients, and the same patient has a G tube that is draining for gastric atony, and they basically connected it. Now, I recently had a patient with a malignant bowel obstruction. He actually had a gastric outlet obstruction due to cancer, and he had the same exact setup. He had a feeding jejunostomy and a decompressive gastrostomy tube. And before I met him, we were just throwing away the gastrostomy tube. We were feeding him distally, but we were also giving him IV fluids because of all the fluid he was losing. And so, I sort of recreated this historical picture. Didn't work out so well. I'll say it didn't work out great, but it made for a nice photo. Anyway, moving forward. So the fistula clisis is technically, it's defined as infusing enteral nutrition into a distal stoma of a fistula. And then you can or cannot, you may or may not choose to reinfuse the output of the proximal fistula. And that's the second part, which is the reinfusion of the succus entericus, right? Now, just conceptually thinking, like, you can think of ECMO as, you take a fluid out of the body, you do something to it, and then you put it back into the body, right? That's extracorporeal membrane oxygenation. And you could probably say the same thing about hemodialysis. You take fluid out of the body, you do something to it, and you put it back in. So what we're really talking about is essentially ECMO for the GI tract, right? Extracorporeal gastrointestinal circulation, right? So the succus comes out of the body, you do something to it. In our case, we strain it and get rid of all the solid particulate matter, and then we put the liquid back into the body, which is, by the way, where it belongs, right? You don't want it doesn't belong in the trash. It belongs inside the body where it can be reabsorbed. And so there are 2 types of patients that you would be considering fistula clisis for. The first is a surgical candidate, and the second is a non-surgical candidate. So for the surgical candidate, you would the reason why you would do the fistula clisis is to maintain the mucosal integrity of all that distal bowel and to promote intestinal adaptation. So think of it. So if this patient's had a fistula for over a year, and I take him to surgery and put them together, I don't want that bowel distal to the anastomosis to be seeing succus and tube feeds for the first time in over a year immediately after surgery, right? It's not going to work well. It's not going to absorb well. So I want it to be, maintained and remember what it's like to work, right after my surgery. Now, for the patients who are not going to go to surgery, who are not a surgical candidate for whatever medical reason, they're too frail, they're too, whatever, the goal of fistula crisis then is actually to liberate them from parenteral nutrition so that they can avoid the complications such as line infections and thromboses, and also hopefully to decrease hospital costs or healthcare costs. Now, the theory underlying this is that the chyme, the stuff that we're normally throwing away, if you throw it away, it will cause gastric hypersecretion. And the mechanism, the underlying reason for this was described actually over 40 years ago. So there's this thing called the ileal brake. Actually, I guess it's just under 40 years ago. So the ileal brake is a neurohormonal pathway whereby stuff that happens in the distal part of the GI tract can actually influence what's going on in the proximal portion of the GI tract. So what happens is when the ileum, okay, when the terminal ileum sees food or GI hormones, bile, pancreatic secretions, all of that, it actually transmits signals back up to the stomach and the duodenum and says, "Hey guys, calm down. All right, it's all good now. It's time to shut down." So the brake then slows down gastric secretion, peristalsis, and bile and pancreatic enzyme output. Right. So after the ileal brake, there was a jejunal brake that was discovered, and then I also deleted the slide, but there's also a colonic brake described. So there's all sorts of physiologic brakes. So without reinfusing the chyme back into the distal bowel, you're basically driving a car that has no brakes, right? And so you're contributing to increased fistula output. Another reason for putting it in, and I mentioned this earlier about the surgical candidate, is the intestinal adaptation, which is important for liberating a patient off of parenteral nutrition. And there have been multiple publications showing that the adaptation is dependent on intraluminal pancreatic biliary secretions and enteral nutrition. All right, so when I walk into a room and I see a bag of beautiful bile and secretions, I sort of look at that like liquid gold, and when I see the nurses throwing it away, I basically think they're like basically throwing away the baby with the bathwater. All right, so there have been studies. This is a case report, a case series, sorry, of 30 patients, where by reinfusing the upper GI tract secretions back into the distal bowel, they reported a 30% decrease in the fistula output. Right, here's a beautiful example of the ileal brake in action. All right, there have been several other series reported after that. Here's a great example of radiographic studies showing in the left panel, in panel A, this colon looks terrible. It's all shriveled up. The lumen is tiny. There's no folds. It just looks like a terrible colon, right? And so they did fistula crisis and chyme reinfusion for 50 days, and then the panel on the right looks like a normal, healthy, happy colon. All right. In this series from China, they did a case control study, and they reported an even more impressive decrease in the proximal fistula output, a 50% decrease. They also reported significant improvements in all sorts of other biologic measures, biologic biomarkers such as bilirubin, transaminases, etc. Clinically, in their case control study, they reported that patients who got fistula crisis and reinfusion have decreased charges, length of stay, and lower rates of mortality. Vanessa Kumpf is a pharmacist who has written extensively about this. She was the first author for the Aspen and Philanpe guidelines on nutritional support for fistulas, and she also recommends that with their survey of the evidence, they also recommend fistula crisis. Right, and then the Europeans are also led by Pierre Singer have also recommended the fistula crisis, or enterocutaneous as they call it. So the practical considerations in the final few moments, minutes of the presentation, we'll talk about the practical considerations. So who would you choose to do this for? So firstly, if you think that this fistula is going to close, you should not do fistula lysis, because by cannulating this fistula with the feeding tube, you're going to definitely prevent it from ever closing. Okay, so you want to select your patient. Ideally, it would be a proximal fistula, okay, with high volume liquid output, right? If it's solid stool that's coming out of the fistula, you're not really gonna, gain any benefit by putting solid stool back in. And most importantly, you need a compliant and motivated patient. All right. Now, everything that we talked about up to here, all of the nutraceuticals and the ancillary treatments, that should be like, you should have completed and stabilized all of those before you begin this process. Like I said earlier, phase 2 is define the anatomy, etc., etc. Now, the fistulogram is very important because, if the fistula is very distal, and you'll never know, like you'll be surprised. But if you do the fistula and you're basically looking at the colon, I unlikely to benefit. However, I will say that since I made this slide, I have encountered 2 patients who've only had 15 centimeters or less of bowel, of small intestine, distal to the fistula, and then the colon. And I said, you know what? Let's just give it a shot. Let's try it. Why not? And I will say I'm super surprised, but even with as little as 15 centimeters of bowel, the patients were able to get off of TPN, and you wouldn't believe it, but like coming out of the colostomy was like solid stool, and the patient was having the other patient was having bowel movement. So again, like I said, I'm continually amazed at the ability of the bowel to adapt. So now, even if it's super distal and unlikely to benefit, I still give it a shot. I still say, hey, why not? Let's see if it works. Now, this is a fluoro study of a patient where it was very high, it was very proximal, the fistula. So we were definitely going to feed this patient in the fistula. Now, how do you get the feeding tube in? It could be as simple as just shoving in a tube at the bedside, right? So that's ideal. You just shove it in and away you go. The next step is, if that doesn't work, or if you're not comfortable doing that, you can ask interventional radiology to do this. And then finally, if they're not able to do it, then the surgeon can also do that. You can basically use any type of tube you want, and it can be held in place. Like, if you can use a Foley and then inflate the balloon to hold it in place. You can use the standard pigtail catheters, or you can suture it in place. Any sort of soft catheter will work, right? You don't want to put a chest tube. You don't want to put a rigid tube in, but anything that's soft is fair game. All right. Here's examples of a fistula that they just basically shoved it in. Now I selected this panel so you can see. So if you look at the right panel, in order to collect the fistula from the proximal and cannulate it, they have to make it come out through the same bag. And as you can see, they poked a hole in it and they tried to seal it up with surgical tape. And as you can see from the staining around the side of it, it's just not working out. This thing is leaking all over the place. This is a surefire recipe for the patient to become no longer compliant and no longer motivated. So one device that we have found to be helpful is the Hollister Universal Catheter Access Port, which is basically like 2 cones that fit within each other, and they create a nice seal. So here's an example of a patient that we used it in, where you basically snip your little hole, but instead of trying to wrap it up with tape, we use the Hollister Universal Access or a competitor. This is not the Hollister, but this is something else, but it's a similar concept. And as you can see, it's all nice and it's not leaking and it looks great. All right. I have no relationship with Covidian anymore, but in our hospital we only have the kangaroo pumps, and these are good because it has 2 channels, right? It's got the normal tube feeding channel, and then there's a side channel for the flush, and that's the channel that we use for the fistula lysis and reinfusion. So we'll take the succus, the fistula stuff. I will tell the patients to pour it through a coffee filter, like a standard, those paper coffee filters for like a Mr. Coffee thing, and then to strain it, to get rid of the solid stuff, and then the liquid we just pour into the little collection bag, and then you can program it for whatever you want. So what I usually do is I usually start at a low rate, 10 cc's an hour, and I prepare the patient. You know, I manage their expectations, and I say, hey, listen, you know, you're going to have a little bit of abdominal pain, a little bit of cramping. That's good. That's really what you want. That tells you that it's working. That usually helps with them. Sometimes, you know, they will experience a lot of nausea, vomiting. I think it's probably psychogenic, but you say, okay, no problem. We'll stop for today. We'll try again tomorrow. And then over time, you'll find that these adverse bodily somatic reactions will usually go away. And then as they tolerate it, then you start to go up. You start to increase your tube feeds until you're basically refeeding everything. Okay, we also will try to tube feed concomitantly with it, so they're getting the tube feeds and the fish and the succus. And then you just basically continue to monitor, and then you use your judgment and start weaning down. Now, sometimes you may need to give extra. Now, the ideal patient is somebody who's eating food that then you just capture everything and you know, strain it and put it back on its way, and they don't require any additional tube feeding or TPN. But even if you're able to liberate from TPN, some of these patients, up to 60%, will require actually tube feeding in order to maintain their nutritional status. And obviously the tube feeding is through the fistula feeding tube. There's, you know, the potential complications are very mild. There's really no way that you're going to harm this patient long term. So I feel very comfortable giving it a shot and seeing how far you can go. And mainly, I would say the main barrier to implementation is the getting over the mental barrier of like, you want me to take poop and put it back inside me, but you just have to sort of reframe their approach and say, no, this is liquid gold. This is good stuff. This is your ticket out of the hospital and off of TPN. And so sometimes they just can't get over that barrier, but most of the time with persistence and with compassion, you know, you usually can get them. So I'm going to wrap up now. In summary, the difference between 20th century fistula management and 21st century management is listed here, right? So we used to do strict bowel rest and TPN. Now we've done a complete 180 and we try to push the oral and enteral nutrition as much as possible. There was no such thing as nutraceuticals in the previous century. Now we have a whole slew of nutritional pharmaceuticals that have been shown in animal studies mostly, but also in some human studies to facilitate wound healing. The negative pressure wound therapy, or the VAC, is now a workhorse and a standard, you know, step one of our armamentarium of local wound care. And then now we do fistuloclysis on basically everyone that we can for a multitude of reasons. And in summary, so when you're consulted or when you approach a patient with a fistula, just keep it simple. Just think of the 3-phase approach: stabilize the patient, define the anatomy, and then wait. Wait at least 6, ideally at least 12 months, even longer if the patient can stand it. We do the NPO and TPN very briefly at the beginning when we first meet them, just to get an understanding of the baseline output and to stabilize their fluids. And then after that, we really aggressively go for oral and enteral nutrition. I already talked about the nutraceuticals, the negative pressure, and the fistuloclysis. So going quickly, so the learning assessment: which of the following antidepressants has the highest incidence of anticholinergic effects? I hope if you were paying attention, you'll recognize that it's amitriptyline. So what was a disadvantage in the treatment of major depression is actually a desired side effect in the treatment of short bowel syndrome and fistulas. Okay, when is the optimal time? As soon as possible, within 4 weeks, at 3 months, or at least 6 to 12 months. I hope you will agree with me that waiting at least 6 to 12 months is ideal. And then the final learning assessment: in which of the following scenarios would fistuloclysis be most appropriate? So a low output with thick output, a fistula of the sigmoid colon, a proximal high output fistula, or an internal fistula? Answers should be obvious: a proximal high output fistula. Okay, and with that, I'm going to conclude. I'm sorry I went a few minutes over, and I'm happy to take any questions.
Hi, Dr. Ye. Thank you for an absolutely fabulous presentation. I just got a text from a friend of mine who's an RD who said, "That's it, I'm moving to Miami to work with him." So
I'd love to. Send her my information, him or her. Send him or her my information. We would love.
I will do that. So just a couple of questions. Actually, I should make that too. I just got another text. So which diet consistency would you recommend when the oral diet starts?
So I think we're probably a little bit old school with this, but we take our time. We start with the brat diet, then we go, okay, so we'll start with liquids, right? We'll do this sips of clears, then the clear liquid, then the full liquid, then the brat diet, then the modified brat diet, then the short bowel diet. So we go through these stages, and I will say that you can only constrain the patients to this if they're in the hospital and they have no other choice. If you try to do this as an outpatient, they're gonna cheat. Like that. I mean, I just accept it, right? So ultimately, this is not a elective colorectal surgery ERAS patient. We're not talking about a fast track patient that you can just skip. So I just basically go super slow and conservative, but most of the time we can get them eventually to a regular diet.
That's great. Okay, and there's one more question here. What volume of ECF output would be too high to attempt PO or EN? Like, which of those patients do you just make sole TPN patients?
Well, that's a question that is case dependent, right? Because if you have a frail little 35 kilogram person, they may not be able to tolerate more than 500 or 600, without going into acute renal failure. Conversely, you may have somebody, a young healthy patient with a lot of reserve who can tolerate 1.5 liters or 2 liters, who can do fine, and also, depending on their compliance, most of these patients are going to cheat anyway, right? So in the hospital, when we bring them in for tuning up, right, and I'm going to be honest, like these are complicated patients that even if you get them out of the hospital, they usually end up coming in like every 2 to 3 months for some reason or other, right? They get a little bit too lax with their diet and they go into AKI, or they're not doing a great job with their wound ostomy manager and they get like a cellulitis or skin irritation or pain or whatever. So I would say that I wish I could give a blanket statement and a single number, but it's really case specific. And these are actually the patients that I will sometimes use octreotide for, right? So if I'm really struggling, if I'm like, man, you've had 3 line infections, I really just gotta get you off of parenteral nutrition and your output is too much, I will try them on octreotide to decrease their fistula output so that I can give them a break from the TPN. I don't know if that answers the question, but that's just my impression.
That's a great answer. I think that is all the questions that we have. I'm just checking here. And we thank you so much. I know you're on vacation, and now you can go back to your vacation, and we will send it over to Vivian now to complete the conference. And thank you again. Wonderful presentation.
Thanks for having me. It's been great.